Hello, everyone. My name is Safwan Malik. I have a question. Have you ever woken up tired after what should have been a full night's rest? Today, I'm talking about sleep disorders, not just being tired, but medical conditions that disrupt sleep quality or timing and then mess with daytime life, which includes focus, mood, performance, and safety. Clinicians actually classify these into six groups in the International Classification of Sleep Disorders, which gives us a useful map. My game plan is simple. First, why does this matter for students? Then, the big disorder categories. Then, quick ways to self-screen. And most importantly, what actually helps. I'll keep it practical so you can leave with a couple things to try this week. All right, let's set the stakes. So, why does sleep health matter? Sleep is not an optional upgrade. It's basic biology. It empowers memory and learning, which is kind of the whole point of being here, and it stabilizes mood and reaction time. When sleep is chronically short or low quality, inflammation climbs and glucose regulation gets way worse. That's the long-term health effects. In the short term, it means mistakes, slower thinking, and sometimes drowsy driving, which is a real safety issue for commuters. For students, poor sleep shows up as lower energy in morning classes, harder time retaining material, and a general productivity tax. So this isn't just a feel better type of thing. It's grades, safety, and health. With that in mind, here's a clinical map so the rest of the talk makes sense. So how do clinicians classify? Doctors and doctors split sleep disorders into six groups. One, insomnia, sleep-related breathing disorders like obstructive sleep apnea, central hypersomnolence such as narcolepsy, circadian rhythm disorders, parasomnias, which is sleepwalking, REM behavior disorder, and also sleep-related movement disorders like restless legs. Each category has specific criteria and tests, and people can have more than one at the same time. This slide is the this slide is a roadmap. I'll hit the high impact ones next, insomnia and sleep apnea, then touch on narcolepsy and circadian issues, parasomnias and movement disorders, and then finally, we'll get to screening and action steps. So, insomnia, which is the most common, isn't just a rough night here or there. It's trouble falling or staying asleep, plus daytime problems, fatigue, brain fog, irritability, and it's considered chronic at 3 or more nights a week for over 3 months. A lot of insomnia sticks because of conditioned arousal. Your brain learns to be awake in bed, and irregular schedules that keep the system confused. The best first step is CBTI, a 6 to 8 session program that retrains timing and habits, stimulus control, sleep window scheduling, and cognitive tools. Meds can help short term, but they don't reteach your sleep system. CBTI does. Keep that in mind as a theme. Durable skills beat quick fixes. Obstructive sleep apnea is next. Red flags are loud snoring, witnessed breathing pauses, morning headaches, and daytime sleepiness. It's not just annoying snoring. Untreated apnea raises risk for high blood pressure, diabetes, heart disease, and stroke. So how do you find it? A home or lab sleep study. The most effective treatment for adults is CPAP, which splints the airway open. If CPAP isn't tolerated, there are oral appliances or, for selected cases, surgical options. Risk is higher with a larger neck, nasal obstruction, alcohol closer to bedtime, and a high BMI. The big idea is treating apnea isn't cosmetic. It's a cardiovascular prevention move that also gives you your alert daytime back. Now on to narcolepsy and central hypersomnolence. Central hypersomnolence disorders are about irresistible daytime sleepiness. Narcolepsy can include cataplexy, where strong emotion, like laughing, triggers sudden muscle weakness. People often feel better after short naps, but the sleepiness soon returns. Diagnosis uses an overnight sleep study followed by a next day multiple sleep latency test, but only after ruling out insufficient sleep or sleep apnea. Management mixes safety planning, scheduled strategic naps, and wake promoting meds. For students, disability services can help with reasonable accommodations, like flexible exam timing or brief nap breaks, so daytime functioning is protected. Next, onto circadian rhythm. Now the body clock piece. If your internal clock doesn't match your work or class schedule, you can feel tired at the wrong times. Delayed sleep wake phase is common in young adults. You simply just can't fall asleep early even if you try. The main therapy timing, the main therapy is timing. Morning light shifts your clock earlier. Timed melatonin can help that shift. And the anchor habit is a consistent wake time every day, including weekends. Also, minimize evening bright light and heavy late night screen time, then get bright daylight soon after waking. Think of it like training a pet. Consistent cues at the same times create predictable behavior. Parasomnias and movement disorders. Parasomnias include sleepwalking, night terrors, and REM behavior disorder where people act out dreams. The priority here is safety. Clear floors, secure doors/windows, and protect bed partners if needed. If behaviors are frequent or violent, that's medical evaluation territory. On the movement side, restless leg syndrome and periodic limb movements, fragment sleep can lead to daytime fatigue. With RLS, checking iron can matter. Lifestyle tweaks like cutting late caffeine and alcohol might help. There are targeted treatments when symptoms are significant. The takeaway, these aren't quirks, they're fixable sleep disruptors. Onto a quick self-screening. Two quick tools you can try tonight. First, the Epworth Sleepiness Scale. You rate your chance of dozing in everyday situations. Scores run 0 to 24. 10 or higher suggests excessive sleepiness and it's worth a clinician visit. Answer it for a typical week, not your most exhausted day. Second, hmm, stop bang screens apnea risk. Snore, tired, observed apneas, pressure, high blood pressure, BMI, age, neck size, gender. High scores don't diagnose you, but they flag who should be evaluated. If you snore and still wake up unrefreshed, or you doze in class or at red lights, please get checked. So what actually helps? Here's your punch list. Insomnia, start with CBTI. A clinician guided or app-based programs exist and are mostly skills focused. OSA, CPAP first. If it's tough, explore mask fitting, humidification, or oral appliances. Also address weight, alcohol timing, and nasal issues. Circadian. So lock in a consistent awake time. Get bright morning light, time melatonin correctly, and make sure you have dim evenings. Some daily habits could include a 15 to 30-minute wind down routine, a caffeine cutoff, and screen limits before bed. If your Epworth is 10 plus, you have loud snoring with pauses, chronic insomnia, or any drowsy driving, move evaluation to the top of your to-do list. Thank you for listening.